Okay, great. This is Fausto Ferres again. I just moved from lab 1 to lab 4. We were in the valve heart case. Now we came to a coronary case. It's my pleasure and privilege to introduce Ricardo Costa and Rodolfo Staico and also Lue Nakayama. We're going to be doing the case and I'll be moderating like we did in the last. We have a great team of nurses. Fernanda is here and hopefully we have time now to show this case. Ricardo, the word is yours, please.
Thank you, Fausto. Can I have the slides, please? So this is a case, a 50-year-old female patient. Her clinical presentation was a class 2 to 3 angina, which is worsening in the last months as risk factors for coronary artery disease, hypertension, diabetes, type 2, dyslipidemia, a very important family history for cardiovascular disease. As you can see, 2 brothers and 1 sister, so all the siblings have MI at a relatively early age, and 1 brother with 35 years old. As for the medication, she is under losartan, simvastatin, hydrochlorothiazide, and laboratory tests is a normal renal function, LDL 127. She also underwent in a different location for a echocardiogram, which showed preserved LV ejection fraction. The resting EKG did not show any significant changes here. No abnormalities were called. And she underwent a few months ago on a stress test that showed a ST elevation in AVR and also ST depression in the anterior leads. She came to our hospital for a diagnostic angiogram. As you can see, that's a right coronary artery.
That was yesterday?
That was yesterday, exactly.
It's important.
Dominant RCA with a moderate disease in the mid portion. We can see here in the cranial view, same thing, is an eccentric lesion around 50-60%, but a very long distal branches. Here you can already appreciate a very tight stenosis in the distal portion of the left main, a large left main, and you can see also a large circumflex in the LED. Now moving to the cranial view, we can also see the lesion is not clear in both previous projections. The size of compromise in the circumflex, which is a very large vessel. Here in the LAO cranial, we can see less the lesion, but it's along left main as well. And here in the spider view, we see some overlap of the L circumflex origin, but also the compromise of the os of the LAD as well. The LV function, as already expected by the echo, is a completely normal function. And we also assess also some scores here. Like the syntax score, it's 13 angiographic syntax score 1. So basically we're taking the moderate lesion from the RCA and the left main lesion involving the bifurcation, but mostly the os of the LAD, not the os of the circumflex by the angio. The syntax score 2 showed that both CABG and PCI will be recommended for this patient considering revascularization. The syntax score 2020 also low risk for MACE at 5 years and mortality at 10 years, as this is still a very young patient. And some bleeding risk scores that we like to do as well in the routine. So it's a low risk for bleeding for the Crusade score. Precise depth considered very low as well. That can help as a strategy for depth in the long term. The ERO score and the ST score also very low, less than 1%. And so we can summarize the case. So this is a 50-year-old female patient, family history for myocardial infarction, diabetic, a worsening angina, positive stress test, moderate lesion in the RCA, distal bifurcation, and the low risk scores, whether for angiographic, syntax, and also the bleeding scores.
So, great, Ricardo. And let me ask you a very simple question. And why these patients here in the cath lab? Why she's not in the operation room? How did you decide it?
Yeah, that's a very important point, because we've seen what's happening in the last years with the evidence and improvement of the technique, the PCI. Now left main, we can say, has become a routine in clinical practice, as being less invasive, and many clinical trials have shown very equivalent results comparing CABG and PCI. And of course, PCI has an advantage: the patient can recover in a much faster way. And also, I would say that only the very, very complex patients with a very complex anatomy, we're still referring for surgery. In our practice, this has become a routine as well.
Should we talk to the surgeon to decide that? Do we need a heart team to make a decision?
Yeah, I think for the more complex, yes, definitely. These patients, we're never going to do this ad hoc. We always will take off, we discuss the options, discuss with the patients. It's important that they understand surgery is an option as well. And many times we involve the surgeon. But I think these patients, based on the evidence, we feel comfortable on treating in the cath lab now.
Yeah, as let me tell you, I was here in the cath lab later in the afternoon yesterday, and when we saw this diagnosis case that was being performed at that time,
Exactly.
and we were supposed to do another case, but this case came from our routine. That's very important. This patient had probably a tight left main since November when she had the stress test. And now she came to our cath lab, and we saw the anatomy and decided to bring this case today. So what have you done so far, you, Rodolfo, and Louis, Ricardo?
Okay, so basically this patient, we are using 7 French, we're doing femoral. Yesterday she did a diagnostic.
Can you see the image now, please?
Yeah, yesterday we did a diagnostic cath by radio, but it was not a very large radio, so that's why we decided to go femoral and 7 French. Always when you deal with a bifurcation, even though you're not going to do elective double stenting, we like to do 7 French. So here we see the RAO view, and very, very tight stenosis. As you can see, it's not very easy to see the very awesome the circumflex. We like to go, we went very caudal here. Doesn't appear to be a significant stenosis, but it's a circumflex with some ectasia. Can you go to the next one? Now we see the cranial view. So LAD has some mild disease in the mid portion, in the mid to distal portion, but appears to be a relatively good landing zone by the level of the diagonal. Next. Here we see the spider again. We see some overlapping of the takeoff of the circumflex. So we're a little bit, concerned about how easy it will be to cross with a guide wire.
So how severe is the right coronary artery?
By
about 60, 70?
By angio, we felt like around 60, very
70.
centric lesion.
So you're going to treat the culprit lesion today.
Exactly.
Okay. So what have you done here?
So the next one. So just to show how we recross, we're using here a BMW, which is a working horse wire. It was very straightforward. We could get into the circumflex here.
So go to the circ first?
Circ first.
Okay.
And then here we go into the LAD.
All right.
So we went very straight. So here we are. We thought about treating this patient. If you could have the slides back, please.
Can you see the both guide wires over there?
We can see, just to show the final one. If we take like the latest evidence for approaching as a complex technique with 2 stents, here's the definition criteria. This patient does not meet the definition criteria. That's when you might have some benefits of the complex procedure. So we want to do provisional here. Angel, please. And we thought about doing IVUS here to assess.
So when you do IVUS in a case like this, you do predilation first? We have to do predilation because if you advance. Can we see what you did here?
Yeah,
please?
So we're going to do this now.
What kind of balloon did you use?
2.5.
2.5 by 15.
So it's a semi-compliant 2.5 by 15 just to open the vessel so we can advance with more comfort the IVUS catheter.
So you're going to predilate right now?
Exactly. So we're advancing here. You can see the fluoro here. Okay.
So you choose to go to the LAD to the predilate?
Yes, we're going to do LAD, left main LAD.
Because the severe lesion is more prominent to the LED.
Exactly.
Okay.
The ostium, the LED. And always when you do a bifurcation that involves both branches, it's important to do the IVUS from both branches, the pullback, not only one branch.
No, contrast.
Okay.
So here you can see we are advancing
The balloon.
the balloon. So the balloon came very easily here.
Okay. How pressure you're going to use that?
What pressure, Rodolfo?
10.
So
10.
10. Okay, this is very fast,
Okay.
and that should be enough. Control.
Huh?
Right. Okay.
Okay.
So I think
It's enough to have the IVUS
that's
in there.
enough to go with the IVUS catheter.
So doesn't matter how long you be inflating, just 10 or 15 seconds. Is that
Exactly.
right? Okay.
And especially because you never know how much the patient can tolerate some
Okay.
ischemia in the left main.
Left main.
So we're going to go with
You
the
can-
IVUS now to the LED.
I think you should decrease the ischemia as much as you can when you are doing this procedure. I think it needs to be pretty fast because you cannot have an accumulation of ischemia during the procedure.
Exactly. That's very important. Patient can become unstable.
How big is this left main by angel?
We
4.0?
thought about 4.0.
Or
But
4,
if you-
4.5?
Yeah, but if
Rodolfo, what is it? 4.5.
you might have some
Do
more
you
diffuse disease
routinely
there.
use IVUS to do a case like this, or can you have, if you have only angel,
Yeah,
you can do this procedure?
in our practice, we're using more and more IVUS, especially when it's more complex lesions. So I'd say in the last years, about 60 to 70% IVUS use. But when you have a more obvious anatomy, you might skip that. But always is a good idea to use it. So I'm taking here the guiding catheter from the os of the left main. That's a very important technical aspect as well. I'm advancing here where we think could be the landing zone. Could I have the image of the IVUS, please? Okay, so I think we can start the pullback from here. I'm pushing here. Live, please. Live,
Okay.
live.
Can
Okay,
you also have the, well, okay, you can see the angel where the IVUS catheter is in the angel.
can we have the angel too? The angel and the IVUS side by side, please.
Okay, good.
So we start in the mid portion. You can see some disease there. It's a large vessel with diffuse disease. And lumen is about 3.0, but the vessel is about 3.5 here. Here more the proximal LED, you see some negative remodeling. We see a small branch coming at 1 o'clock, and we should be coming now towards the ostium. We see a more tight stenosis, calcified, very tight stenosis here at the very ostium location, taking the distal portion of the left main. And diffusely disease, the left main is, you're right, about 4.5.
Yes.
There's some diffuse disease here. And as we come here proximal to the very ostium, we don't see disease anymore. So I think that's a bit of a challenge here to find the right landing zone because it's diffuse disease into the LED.
What did the IVUS help you in a case like this? Are you going to do the circ too, or?
We're going to do the circ as well now.
Okay. Just to see how
ostium
much
involvement.
disease we have in the osteum.
Exactly.
Circ osteum. So
Exactly.
if you do IVUS in the left menu, it's very important to go to both branches. We cannot just stay in one branch. We need to look at all the bifurcation and to have a better strategy if you are doing guide by IVUS.
Yeah, now we go in the circumflex and to confirm if the ostium is free of significant disease.
How long is the disease in the LADs? Seems to me go to the maybe 20 or millimeters
Wagner, can you
in the
show
proximal
us here?
part. I mean, I just thinking about where the place to deploy the stand, the best place in the LAD. Now you're bringing the IVUS to the circ. Is that correct?
Yeah, so advancing here, the IVUS to the circumflex.
Okay.
I'm giving some better support
Great.
here with the guide wire.
Let's take a look.
Can I have image, please, Wagner? Next one.
Okay. So bring the catheter back to the aorta. It's important.
Okay, so we have live here now,
Yeah.
and I'm going to just start the pullback. You can see where the guiding catheter is. Very large vessel at this point. It's about 4.0. We see some very mild disease, eccentric. Here, no disease. Some ectasia here. And you can see the wire coming at 9 o'clock from the LAD. So it really looks like that's a free of disease ostium of the circumflex, very large vessel, which make us very comfortable, ready to go with a provisional stenting from left main to the LAD. And here we're just going to the ostium, okay, and we're done here, okay? So Wagner, the measure from the ostium of the left main to the LAD to that point that we thought could be a good landing zone. By visual estimation, Fausto, we consider maybe a 28, 3.5 by 28 should be enough. But let's see what the IVUS tell us as well. So,
May we have the IVUS in the large screen now, please? Great, thank you.
so 26 is it's telling here. So I think 28 will be fine, but then we go up to the ostium of the left main, which is always a good idea
Okay.
because you have more diffuse disease and you can have some negative remodeling. Okay? So can we have the stent 3.8 por 28, por favor? 3,5 por 28? Yeah.
So we are choosing 3.5 by 28 because you don't want to touch with like a 4.0 in the distal part of
Exactly,
the
to
artery.
avoid dissection,
Okay,
that's some
to avoid
disease there, but that's a good landing zone.
What did the IVUS help you to do a case like this right now after you have the images? Could you do only by angel or not? I mean, at least by the pre-procedure.
Yeah. Yeah, I think that's a very important point because many advocate that you should not be even considered to do a case this without IVUS. I don't think we have.
So you think IVUS is mandatory evaluation by IVUS in the pre-procedure?
I think in a case like this, I think it's helpful, but
Okay,
I think we have learned a lot from IVUS, and you can apply what we have learned as well.
let me ask you the operators
As we
here
do
while
the
you're
procedure.
working. Louis Nakayama Ore and our youngest staff here at the table. Would you use IVUS to a pre-evaluation, or would you just with the stand?
I think we are trained to use only the angel.
The angel.
We feel comfortable to do
Okay.
that.
How about
So-
you, Rodolfo?
Test. Test.
Okay, now we are in a critical part of the procedure to position the stent. Take your time, Ricardo. We also have a fellow here. It's
Test.
Bastante cabo
Lucas
aqui,
Lemos
bastante cabo.
from
Sem pegar o ramo,
center
o ramo
part of the
diagonal.
Brazil,
Test.
Tirar
from
os
Mato
cabos,
Grosso.
os cabos.
He's also helping us here.
Test.
Actually, we have 12 interventional cardiologist fellows in our lab.
Vamos filmar?
That's pretty busy. And in the 6 labs that we have here.
Yeah, so I think we are comfortable here with the
Yes.
position.
Take a look at the position now.
Low pressure.
Okay,
low
can
pressure.
you, may we have only the angel in the large screen now, please? Just to look at the
Baixa
position.
pressão, tá? Onde está o
Angel in the large screen, please.
Z8?
With no IVUS, if it's possible.
Okay.
Okay,
So we
Great.
deployed with 8 atmosphere low pressure because it's a diffuse disease.
so you deployed that 10?
Eight
atmospheres.
atmospheres.
8 atmospheres,
okay.
yeah.
You bring it back, the balloon, and go up to?
2 millimeters back.
Went up to 13, 14?
12.
12.
With 12
12.
atmospheres.
And
12.
always careful
Great.
with the manipulation here, the proximal guide
So
wire.
they deployed at 8 atmospheres, don't cause injury in the distal part of the stent, and pull back the balloon a little bit and go up to 12 atmospheres. And you can ask me, why you're bringing the balloon back? Yes, because the left main is 4.5 and the balloon is 3.5. We are not gonna touch the wall in the left main.
Balão
Just
de pós-dilatação 3,5 por 20, por favor.
3.520.
3,5 by 20 to post-dilate.
Okay.
And then we target here the distal portion of the vessel.
Take your time. We
And then
still have time.
we're going to go with a proximal optimization with a larger balloon.
Okay.
Mais mulher? So 3,5 by 20 now.
So you're going to optimize the distal part of the stent now.
Exactly.
With the 3.5.
Exactly. The LED, the proximal LED.
Okay. Yes.
And as expected, you do see some worsening of the osteo of the circumflex, even though there's no significant disease there, but probably due to carina shift here. Okay. Now, it's very important that you take your time, you optimize, and you do this in a very stepwise approach. So first, you do the stent in the distal portion, then you do the proximal portion. Then if you have to deal with the compromised side branch, you deal this later. You deal with it later. Don't do the opposite. So I'm advancing here, and non-compliant 3.0 by 20 balloon. I'm gonna go close here to the distal end of the stent. Hold on. Hold on. Okay, I think we're inside here, okay. Then we can go to a larger pressure. How many, Rodolfo, you go here? Okay, so 20 atmospheres. Okay, then we can pull back here to the proximal end of the stent. Yeah, so 26 here, okay. But still, this is not a proximal optimization technique. We're just taking advantage here. So we always like to do control, Louis, control angel here, Louis.
Yeah, you can.
Okay. So,
Vai devagar.
Okay. Okay. So everything is fine here. Can we do a control angel here, Rodolfo? Yeah. Hold on.
You can go.
So you went up to 16, 17,
Okay.
20, 26.
So distal in the LED, he went to 18, and then in the proximal, 26. It's interesting to see, again, the circumflex osteon.
So you went up to 18 the distal LED and to 26 in the proximal.
Exactly.
Is that correct?
Exactly.
26 atmosphere.
Yeah.
Great.
So now we're gonna do a very important step, which is the pot.
Okay.
The proximal optimization technique, because bifurcations, they always have different diameters. It's a unique geometry. So expect a proximal part of the bifurcation, which is much larger than the distal portions. We can have like the finite law that can guide us into this.
Can you have the image from the operators, please, now, not the hands?
And when we do that, what we're doing here, we are posing the struts to the proximal diameter, to this proctal geometry. It's fitting much better. The balloon has to be positioned exactly at the distal end of the carina, where is the flow divider. And with that, we can also create, if you are in the right position, some scaffolding to the osteon of the side branch.
This is a provisional strategy because we did not see much disease in the osteocirc. Is that correct?
Exactly.
Okay. And now you are bringing the 4.0 balloon, 4.5
balloon
by 12? By 12.
So you should be here very,
Okay.
very careful with the positioning here.
This is a very important step. Maybe you should maybe do a zoom and show the audience. Many young physicians are watching us. I think we need to teach with no hurry at this point.
Yeah.
Ricardo, please.
So we're going to do first a control with angel to see the positioning.
Okay.
Okay, see, it's not good enough.
Okay.
We are not at the level of the flow divider.
Can you show that?
Show Louis, please.
Okay.
Look, please. Okay.
Not at the flow divider, not at the coronary. So we need to advance at least 2 millimeters to be exactly at the level of the flow divider.
Okay. In the middle of the circle, I would say.
Exactly.
Okay.
So I'm advancing here.
Let's see again.
I'm advancing here.
Okay.
Very small test.
Okay.
Okay.
Still
a little bit more.
Still not good enough.
Yeah.
Helping.
Maybe you should go with the guiding catheter
Yeah,
a little
guiding
bit
catheter
more.
here, yeah.
Not yet. Yes.
Okay. Test.
Now maybe you film.
Okay.
No, put the
Oops.
guiding catheter.
Guiding catheter here.
Okay.
Okay, now. Test.
No.
A little bit more.
Yes.
I need, okay.
Could you record, please, Ricardo, just to show people?
Vai.
You
Okay.
can record.
Vou filmar.
Okay. Let's move. Okay.
Okay.
Do you think this is a good
So,
position? We need to go a little bit distal.
I like this position, but I think we can go a little bit more because it's a very large circumflex. Hold on.
What are you doing?
I'm advancing a little bit more.
Okay.
Test.
Okay. Test.
So now I feel more comfortable. Let's record.
Let's
Okay.
film. Okay.
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 I think we are
Can you
clear
show
here.
the people now?
Oh, here.
Please slowly. You have time. Please. Let's show to.
Tá pouquinho.
That's a teaching point. It's very important.
Okay.
Do you think it's in a good position?
Good position. Now we're going up.
4.5.
Again.
You went up to
Okay. Can you go up, Rodolfo? Go up.
How much?
15.
Go up.
20. 20 atmosphere.
Okay. So
Okay.
vai.
Ricardo, could you fix again and to explain to the people why you choose this position?
Yeah, so here we want to make sure that we are going all the way in the carina because the proximal part of the bifurcation, it connects to the distal vessels, which is the LED in the circumflex. So up to the level of the flow divider, we call this the carina region, you need to optimize according to the proximal diameter of the bifurcation, which is 4.5. I think we still need to go a little bit more distal to really be at the level of the flow divider, okay?
Okay.
So we did this first. Now we're gonna go back, go forward a little bit. Test. Walter, tá movendo pouquinho. Test.
You want to record?
Test.
I
Okay.
think it's good.
Hold on. Let's. I think we need to show this. So I think we are. I like this position better. Okay, let's go here. So Rodolfo is going. Okay, how many pressure? So 20 atmospheres also. I think we just optimize it where we need to be.
Great.
Okay. If you wanna just to demonstrate, can we do here the
Zoom.
yeah
The stent
the
vis?
stent vis? Yeah,
Okay,
please.
perfect.
So just see how we are exactly at the level where the wire of the
Okay.
circumflex
Can you show
moving out.
this tent vision? Is
We
can you go with this part of the camera or
is
not?
the reference? If you can show.
Can you show the reference here? Okay, that's okay.
So if you cannot, maybe if you use this camera, can you show us in the room, in the lab, please? Okay, great.
Screen. Yeah.
Yes,
Just do a zoom here.
Yeah, if you can do a zoom right here, yes, that's perfect, exactly perfect. Where we should do the
Exactly. Yeah. So now we once we completed this step,
great, thank you.
we are ready to
Great
re-access
technique. Congratulations. That's
the
great.
side branch. Always be careful with the maneuver here with the guiding catheter, with the proximal stent. So
Now you can bring the operator's image, please. Thank you.
Perfil muito alto.
So now what are you gonna do now?
Now we're gonna recross into the circumflex because the vessel, it's a bit compromised. There is okay, but
Yes.
if you compare as before, it's compromised. We're gonna do a control angel here.
Yes.
Yeah.
Okay,
Louis,
ready,
can
Louis?
you put the
Ready,
control
ready
engine?
for the
Or
control.
you're gonna do another one? Okay.
Okay.
Let's
Okay.
You see, Fausto, this is very, very important to show.
Yes.
The image after the pot, even though we did not touch the os of the circumflex, it's better because we are in the right position and we did some scaffold to the os of
Okay.
the circumflex. Many will just leave like this,
Okay.
but we're
So now you're gonna take a third wire, or you're gonna take the
going
LED
with a third wire.
Third wire.
And there's some more recent there's some more recent evidence that kissing balloon, if you're dealing with a very large side branch,
So can you
circumflex is a good idea. You can
you
reduce.
could just exchange the wire, or you need a third wire in this?
That's an option to exchange the wires,
Huh?
but sometimes
It's easier to keep the circ wire
it's easy
and bring
to keep
another
the circ.
one.
Exactly. Here we're going with a pilot with a hydrophilic feature, which can make it easier.
So after the proximal optimization.
Exactly. So here I'm trying to be in a more distal cell.
Okay. So the same kind of wire you were using?
You're using a polymeric wire now.
Now it's a pilot.
Pilot.
A
It's
pilot. You
polymeric.
use the BMW.
Yeah.
Now you have a wire. Okay. So you need to find exactly the middle part of the.
Exactly.
Okay. Take your time. We still have time. We're not in a rush. Okay. Turn. Can you show the hands a little bit? Zoom in the hands just to see what he is doing with the control wire, please. Yes.
Yeah. I
Now
think
just.
yeah, we just need to
Yeah.
already
Okay.
enter. Yeah.
Good.
So it went well. I like the position here.
Tem uma cabeça lá, né?
So
Ali,
now
né?
the next step is to remove the wire from the circumflex,
Okay.
and then we can go with the balloon to open the cells and then perform the kissing balloon.
Okay. Keep
So
the wires separated if you
I'm
don't want
separating
to
here. I like to separate this way. And this is the LED. And we're going to try
Now
to remove
can you show
now.
all the operators the whole image, please? Not the hands. Okay. Good. Thank you.
So I'm bringing back here. Okay, so it's coming.
Okay.
Well,
So you put back the old
I
wire
pull
from
back the
circ,
guiding catheter, exactly.
and
to
now what are you
avoid-
gonna do?
Now we're going to go with a smaller balloon to open the cells, and then go with a larger balloon to do the final kissing.
Could it be the same balloon you predilate the left main, or a new balloon?
We could try. Sometimes you lose a little bit of profile. We like to go with a new one if possible,
Okay.
because it's more guarantee. Não. Eu preciso do gás molhado. Ok?
So it's the same one, 2.5 or
Yes,
2.0.
2.0.
Yes,
It's
2.0.
a new balloon.
2.0
Just to
balloon.
open the
Just to
cells.
open the cells.
Just open the cell.
Just to open the cells.
So if it looks good, can you keep it like this? We know the circ ostium is Aquarius hill of intervention in the left main. Should we leave like
Yeah,
this?
it's a very good point. I would love to have a pool from all the audience that's from the worldwide that's following us
Okay.
here. But
Be careful
I
with
like
the LED
I
wire.
like to do the
is good,
kissing here.
LED wire,
Yeah, we're gonna advance a little bit.
or pull back maybe.
Yeah, let's pull.
Okay,
Okay,
that's good.
and then
No.
yeah. So here, you see how easy it goes.
Okay.
This is just because we did
It's
a
because of
pot
the
in the
pot.
very right position. Exactly.
yeah.
Without the pot, you might not have that. So you see, it goes very easily. You can advance, even if it's stent, if you want
Have you
to.
already opened it?
We already opened.
Just one quick
No.
pressure. So great.
Acho que 3,5 melhor. Ou 3.
What to do now?
Yeah, we are going to do a post dilatation with a 4.0 by
So you're going
12.
to open a little bit more
4.0
the circ.
4.12.
It's already open the circ. I'm going to advance a little bit the wire here in the LED.
Are you going to do a test or no, you don't need it?
We're going to do a test. Always good to have a test.
So the guiding cutter needs to be, I think, in the ostium, no?
Ready, Rodolfo?
Yeah. So,
Yeah. So here.
so the
the
stent did come to the ostium or not? No.
this stent in the left main,
Yeah.
it's not at the very ostium, it's just in the proximal part, but we have enough room for that.
Okay. Good.
I'm just going to go for the cranial view to reposition the LED wire, okay? Because you pulled a little bit.
Okay, that's important.
Coloca, por favor, aqui, Rodolfo, agulha e rotor, para a gente avançar o guia da DEA.
E lá, dá uma olhadinha como é que tá lá. Só ver, discretamente.
Lui, fica no teste, por favor, Lui.
So,
Teste,
Test?
teste.
oh, okay, there is a bifurcation over there. So you're in the diagonal.
Yeah, diagonal.
Yeah, we're going to try to get back here
I
to
think
the
you can
LED.
leave it there.
Testinho, Lui, por favor.
I think it's a little bit. Yeah.
Okay,
Great.
Okay,
Okay.
Great. Great.
okay,
good.
okay, good position. So now we should have balloons in the LED and in the circumflex together.
What size balloons
And
are you
then-
going to use now?
Yeah, so the circumflex, we're going with a 4.0, but a very, very small pressure, just to keep very
Not high
open.
pre- not
very
high
open,
pressure, low
not-
pressure.
Not high pressure. And we need to go with the LED as well together.
Okay,
3.5, please, the same one we used before. 3.5 by
3.5.
20. And that's very important too, Fausto. When you do the kissing, you always need to size according to the distal diameter, the diameter of the LED and the circumflex, not for the proximal part. And you have to do a low pressure. So we just put it here all together. Negative, negative, negativa, negativa, Lui, negativa, negative.
calma, calma.
Okay. So just negative. So we have 2, 4.0 and 3.5. That's why again 7 French
So
is very
1
helpful.
4.0 and
to
1
work.
3.5. So you're using a 7 French guiding?
We're using a 7 French guiding.
Okay.
Yes.
So this lady is 56 years old. Huh?
Exactly.
What are the risk factors for coronary artery disease? Hypertension?
She has hypertension. She has
Young?
dyslipidemia. She
Yeah.
diabetes. But the family
Okay.
history is very important. Very
Okay.
important.
Okay, that's a nice demonstration. Now we are going to use a final kissing. Is that are your plans?
Yes, that's the plan here. So I'm advancing here the balloon. First for the left main LED.
What should we do to avoid a new ostium lesion in the circ, in the follow-up?
Okay, so
Is there any consideration for this?
yeah, if you're doing a provisional, you should not be too aggressive. Just open the cells. The intention here is not to have the optimal angiographic result, but really to have the open cells and to get back to the baseline status.
Okay.
Avoid
to
the
avoid the
stent.
stent.
Avoid the stent always
Okay.
if you can. I think that's the most important.
Good lesson. Avoid the stent if you can.
Yeah. So I'm advancing here a 4.0 to the circumflex. So you see it went very smoothly.
Smooth.
And then you should have the 2 markers in the proximal part put together. Okay, you should not be too proximal. So that's enough here. And then, okay, let's go together. 4 atmospheres. Okay, yeah. If you push forward, you should pull back. Try to get in the position. Okay. Okay. Vai, sobe, sobe. 4, 6. So 6 atmospheres, both
Okay.
together. 6 atmospheres. Okay.
So
1,
yes,
2, 3. 1, 2, 3. Okay.
6 atmosphere for each.
6 atmospheres. That's
Okay.
enough. Yeah. And
So you don't go with high pressure and high pressure
no,
anymore.
because we did before.
Because?
We did before. We
Okay,
already
okay,
post-dilate the
okay.
LED. And also the circumflex, there's no need for that.
So now you're going to do a control IVUS.
Can we do a control angel here?
Yep.
Forte, tá? Okay. So you see,
Great
you see the
results.
scaffold there. It's. I think it's just perfect.
How about the LED ostium?
Perhaps.
What's going there?
I think we can do the IVUS Fausto and have a look there.
But what is your impression about the angel with this? If you don't have the IVUS, can you leave it like this? The LED ostium? Yes? You don't mind
You
about
feel comfortable?
this?
Yeah.
Okay, that's very important.
Okay.
Let's see. Louis, do you
So-
think we need to do an extra work after IVUS, or are you going to stop?
No, I will do only. I'll probably do a report.
Report. Will you do? Why not do a report,
Also,
Ricardo?
that's controversial.
Okay.
You could,
Even between the sting operators here. Huh?
yeah,
It's great.
we could have
This is
back the
democracy.
circumferential geometry, but you know, one tip now is for you to do the kissing balloon not extend too much into the carina. Just
Okay.
take short what we did here. So
Okay.
maybe report is less needed.
Ok. Pergunta pro Dimitri se eu posso
With
ir
low
daqui
pressure,
5 minutos
exactly.
pra lá.
We have not seen that report in terms of clinical benefits are there. Even though theoretically it's a good thing, when I do it 2 stents, I always would do that. I think we should extra optimize the carina, but here I feel comfortable the way we
Watch
are.
the wire in the circ. Okay.
Yeah, we're just advancing here a little bit. Okay.
Be careful with the wire.
Yeah, it's in another branch there. Okay, so
you're going to do circ first? Okay.
yeah, circ first. We see the ostium here,
Okay.
and if you feel comfortable, I
May I
think.
have the IVUS image, please? Great.
Okay, so we can start the pullback. Now what we are seeing here is the proximal circumflex. You can see the angel exactly where we are. Maybe have the IVUS in the bigger screen. And you
We have
see
the IVUS in the big screen. Okay, great.
it's a very large vessel, it's about 4.0. We don't see any signs here of dissection or anything. And then as we approach, some negative remodeling there. I think it's well fit, but most important, it's a full opening into the left main. And that's what we want here. Maybe you can have some progression of the disease. It's a very young patient, so you have full access. And that's what we want here. I see the stent fully opposed here in the left main. So I think it's like
really,
well
really
fit and the proximal is just fine. So we are very comfortable also with the result with the IVUS in the circumflex. Now we're going to see the left main LED. And maybe you want to do some measurements just to show the ostium again, Wagner.
Yep.
Renata, o heparina, tá? Heparin. Já fez, ok.
Que tipo de stent?
So,
Que tipo de stent foi?
okay. So here,
Não tinha que ter usado os dois.
very close to the ostium, right, Wagner?
Queria que usasse um Inspire.
Só um pouquinho. Okay, go frame by frame, please, Wagner. Okay, so here we are advancing in the proximal part. Okay, okay, okay. Keep on going, keep on going, keep on going, keep on going, please. Keep on going. No, 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 Wagner, forward, para frente, forward. Okay, yeah. Yeah, keep on going, keep on going. Keep on going. Keep on going. Yeah, so you see, it's very smooth entrance. It's fully open. That's what we want here. And I think 4.0 was a right option here.
So
You have to size, not under, not
chega
over.
aqui,
You have to
então.
size according to the distal reference. But of course, we went with a low pressure because this is we don't want to oversize in terms of having high pressure. So now I am advancing here to the left main in LAD. And then we can make a decision if we do a report or not, that we can make a decision here based on invasive imaging. So
Okay.
I'm advancing here.
The IVUS.
I'm going to go all the way here. So I
Okay,
have
can
the
you
distal
show
transition,
the angio image, please? Angio image.
angio as well.
Okay.
Again, Fausto, you always have taught us, always pull back the guiding catheter so you can see also the left main.
Yes.
You should not, you should always
Great.
remember that.
Okay, great.
I think we're in the right
So
position now.
that's very important to pull back the guiding catheter to have a better evaluation by IVUS of the ostium. Now, can you bring, please, the IVUS to the
I was in the big screen.
please? Great. Thank you.
Okay, so start pull back now. As we knew, that's a diffuse disease in the LAD, but I like the distal transition. Appears don't see any signs of dissection. Appears to be well sized to the vessel, real vessel size. So we went to 3.5 and we post dilate with the 3.5 up to 18 and then 26 atmosphere more proximal. You see a fully opposed struts into the vessel. In a more proximal part, we see some more calcified region. Yeah, and then you see the opening here. I really don't see any signs of a very important under expansion. Like we can do some measures there, but I feel comfortable. And here we are in the left main. And the left main, the same thing. It's fully opposed and I think well fit to the vessel size. We went to put the 4.5 to high pressure. We did the pot. I think the pot made all the difference here when we recross. And really, I don't feel like a major need for a report here because when we did the kissing, okay, we can have the angiogram again. When we did the kissing, we had the...
Can you take the IVUS out, only the angio now, please?
Yeah, when we did the kissing, we did not pull back too much the balloons there.
Do you need to do the measures in the IVUS?
Yeah, I will do there. Rodolfo, you take care here. I will just go there to see the measures.
So I think with experienced operator, Fausto, the IVUS, they only do is they show us how good the precision of our institution can do with a left main stenting.
Yep. Tá bom. Bem. Mas eles estão vendo tudo lá, ele está sabendo. Lá tá filmando tudo. So can you show the IVUS, please? The IVUS measure now. Okay, in the big screen. Okay, great.
Okay, so here, Fausto, we are in the very ostial position of the LAD, okay? So you see the measure here is about 8.4, 8.5. If I go to the distal LAD, inside the stent, because there's a diffuse disease there, what do I see here is about 8.99. So it's really not a significant under expansion, even though you have calcified, and even though by angio you see some different geometry after we did the kissing. I think the kissing, what we did here was more an accommodation instead of losing the result in the very ostium, because ostium is a very critical location. This is where restenosis really usually occur. So we need to be very careful there. As we go here to the left main, see here this transition here.
Chega mais para cá pouquinho para você aparecer.
Yeah, look at the circumflex opening here from 10
Olha pra
to
cara
12.
dela lá.
This is yeah, maybe you can see me here. Okay.
Can you show Ricardo,
Yeah.
please, with the camera? Who's reading the... Okay, great.
Okay.
A little bit left.
Little bit here.
No, left. Okay, thank you.
Okay.
Yes. Maybe
more,
you can open a little bit.
more, yeah, or open more. Show all of us here.
Yes.
Okay.
Great.
So from 10 to 12, you see this very open here, ostium of the circumflex. There's no significant disease. There's actually no disease there. And we just came back to the early stage, to the original state. This is what we want when you do a provisional. And this is fully open. This is full access. If in the next years, next decade, if this patient evolve with disease in the circumflex, you have absolutely no difficulty on advancing balloons, stents, and doing procedures. As we move here forward into the left main, you see the carina, the scaffold here. We are fully well fit to the side of this left main. So you see 4.35, we went with a 4.5 balloon to high pressure. So this is what we want, 4x46 by 4x35. And we had here to be careful with the sizing, because if you have a 33 stent, we probably want to be in a disease landing zone in the LAD to get the ostium. So we did not have to get the ostium. You can do it, but you don't have to, especially if you don't have a significant disease. And we did not cause any injury outside. And you can see just a very, very good transition to the very ostium of the left main and the transition aorta. No signs of dissection, no sign of compromise, and a full and well expansion in all the portions of the bifurcation. This is what we want. Maybe we can do now the final angels.
The final angel. Can you go back to the angel, please, in the big screen? Great, thank you.
Okay, remove the wires. Yep. Yeah.
Actually, angel is a little bit worse than IVOS. Do you agree with this?
I think it was very, very acceptable result.
Okay, but
I
the
like
ostium,
the
LAD ostium?
Yeah, but we are comfortable based on the IVOS measurement.
Yeah, yes.
Yeah, and I think that's one thing the IVOS can help you.
Yeah. But if you do a QCA in the LAD ostium,
that's going to give at least 20%. Yeah. You see the transition there. We respected the anatomy here.
Let's see the spider view.
Disease, and then the spider. Wagner, puxa aqui pouquinho, por favor. Muito. So now we see the spider. See if the geometry changed a little bit, because there was an overlap in there of the takeoff of the circumflex. Okay. Yeah.
Great.
So I like it very much. What we see here, sometimes you do have some overlapping, but I think IVOS gave us very, very assurance of the result we got there.
Okay, good.
So I think this is...
So I think with this, we can finish this transmission. And Dimitri is still working on the valve. I don't think we have time. Now it's almost to 12 o'clock in the Central Time. That's mean New York in the US. And the case will be recorded, everybody can watch this. And I would like to thank us again, Samir Mehta, who is a great friend, Also Greg Stone, Paul Thurston, Ron Waxman, and Sharma, especially for having us in this very exciting program. And hope to see you next week. Is that correct, Ricardo?
That's correct.
And
You
also
should be here.
to thank all the team here that did beautiful work. See you next Wednesday.
Thank you.
Bye-bye.
Bye.